This is Immunology Unit 4, Lecture 5 on Spirochetes. Here are your objectives. Alright, so the first disease we will cover is syphilis. This is a sexually transmitted disease. Here you can see some charts about infection rates. In 2007, the rate of syphilis was highest in people 25 to 29. It is caused by the bacterium Treponema palladium, subspecies Palladium. It has been called the great imitator because its signs and symptoms are difficult to distinguish from other diseases. Treponema palladium is a long, thin, spiral-shaped bacterium, loosely coiled and motile by internal periplasmic flagella. Syphilis is most often passed from person to person via direct contact with syphilis sores. These sores occur mainly on the external genitals or in the rectum. They can occur also on the lips and mouth. Any contact with air, antiseptics, or sunlight kill this microbe, and Treponema palladium requires the presence of tissue culture cells, a microaerophilic environment, and serum components for growth. Outside of the body in a moist, dark place, it will live no longer than 2 hours. And it's important to note that Treponema palladium cannot be cultured. There was an epidemic in the late 15th century in Europe called the Great Pox, in contrast to smallpox because of its rapid spread and effects. Most physicians treated syphilis with mercury, either orally in vapor baths or topically. Mercury treatment was based on the ancient theory of humors and health. Mercury caused salivation, which was believed to remove the humors causing the illness. Penicillin was discovered to be effective in treating syphilis and gonorrhea in 1943 and is still the drug of choice. Poverty, inadequate access to healthcare, and lack of education are associated with disproportionately high levels of syphilis in African Americans. Next, we'll go over the disease stages. First is the incubation period. Syphilis enters the human body via abrasions in the skin or through mucous membranes. Once inside, it multiplies and enters the bloodstream and the lymphatics. It disseminates to multiple organs in the body. Incubation lasts around 3 weeks, and during this time there are no clinical symptoms. Additionally, there are no laboratory tests that are positive. The next stage is called primary syphilis. The hallmark of this stage is the appearance of a single sore called a canker, but there also may be multiple sores. A canker is usually firm, round, small, and painless. The canker lasts 3 to 6 weeks and will heal on its own, but may leave a scar. Your lymph nodes will be inflamed, and in early stages of primary syphilis, patients are still serologically negative for lab tests. Antibodies will not begin to develop until 1 to 4 weeks after the appearance of the canker. Dark field microscopic examination of the lesion fluid can diagnose the presence of the disease at this point. PCR is an up-and-coming method for such detection in tissues and other specimens, and if it's not treated, the infection will progress to the secondary stage. The secondary stage of syphilis starts when one or more areas of the skin breaks out into a rash that usually does not itch. Rashes appear as the canker is fading, or it can take weeks afterwards to develop. The rash is rough, red, or reddish-brown spots on the palms of the hands and the soles of the feet. Unfortunately, the rash may appear other places, also making the diagnosis more difficult. Sometimes the rashes are so faint that they are not noticed, and they clear up on their own without treatment. second stage symptoms can also include fever, swollen lymph glands, sore throat, patchy hair loss, headaches, weight loss, muscle aches, and tiredness. The disease is easily transmitted at this stage. Large numbers of treponines are present throughout the body. Lesions called mucus patches develop in the mucous membranes, and all serological tests are positive at this stage. The next stage is called latent syphilis. Latent or hidden stage syphilis begins when the secondary symptoms disappear. The person still has syphilis, although there are no signs or symptoms. All tests are positive at this stage. It remains in the body and may begin to damage the internal organs, including the brain, nerves, eyes, heart, blood vessels, liver, bones, and joints. Effects of this internal damage may show themselves years later in the late or tertiary stages of syphilis. Tertiary syphilis is a progressive inflammatory disease that can produce clinical illness in 2 to 40 years after the initial infection. This is also called gummatous syphilis or neurosyphilis. The hallmark is the gummas, Gummas, which are lesions that resemble tuberculosis, and they can occur in the skin, bones, mucosa, muscles, and organs in the body. Gummas rapidly resolve with penicillin treatment. Neurosyphilis can occur during tertiary syphilis and often causes blindness and/or insanity. This can occur during any stage of syphilis, though. This is confirmed by the non-treponemal test, VDRL, performed on cerebrospinal fluid. Congenital syphilis can occur with an untreated mother in any stage of syphilis. It is most severe when the mom has early primary or secondary syphilis. It can cause late abortion, stillbirth, neonatal disease, and neonatal death. Treatment of the mother during the first 4 months of pregnancy almost always treats congenital syphilis. The symptoms are rhinitis and a diffuse maculopapular desquamatus rash, particularly around the mouth and on the palms and soles of the feet. The baby can have hemolytic anemia, jaundice, hepatosplenomegaly, and bone involvement can also be seen. Treponines are present in nearly every tissue of the infant. A definitive diagnosis may be made by direct detection of treponema pallidum in the umbilical cord, placenta skin lesions, or nasal discharge. PCR is an up-and-coming method for such detection in tissues and other specimens. The treatment is a single dose of intramuscular penicillin, which will effectively treat syphilis if the patient has had it for less than 1 year. Additional doses are necessary if the disease is further progressed. Treatment prevents further damage, but does not repair any damage already done to the organs and brain, and having syphilis does not prevent reinfection. So, direct detection, we can use dark field microscopy. Treponema pallidum may be seen in lesion material using dark field microscopy, a direct fluorescent antibody test, or by PCR. For dark field microscopy, the lesion material must be examined promptly, and it requires an experienced technologist. This method is not performed by very many labs. Infection with treponema pallidum leads to the production of 2 antibodies, non-specific or reagin antibodies and specific antibodies. So for non-treponemal tests, these measure non-specific or reagin antibodies and the treponemal tests measure specific antibodies. Nonspecific antibodies are directed against lipid antigens of the treponeme outer membrane, but antigens like these are present in other disease states or conditions such as lupus, autoimmune disorders, pregnancy, and other spirochete infections. Plus, they can be found in normal tissues. This causes a lot of false positive tests. Therefore, non-treponemal tests are useful as an inexpensive screening test. Non-treponemal tests are also useful in monitoring treatment and resolution of the disease because reagent antibodies will decrease and disappear with successful treatment, while specific treponemal antibodies will persist. The antigen used to test for reagent antibodies is cardiolipin, lecithin, cholesterol. Non-treponemal tests are simple to perform and can yield a quantitative result. False negatives can occur with non-specific tests due to tech error, poor quality control, low antibody titers, very recent infection, or prozone. The major disadvantage of non-treponemal tests is that they are subject to false positives. So all positive non-treponemal tests should be confirmed with a treponemal or specific test method. The VDRL test is the only test method usable to diagnose neurosyphilis. It can be run on CSF. Patient serum is heated at 56 degrees centigrade for 30 minutes to inactivate complement. Then the serum is mixed with cardiolipin, cholesterol, lecithin antigen and is examined microscopically for flocculation. Slide flocculation tests are affected by room temperature, so tests should be performed between 73 to 85 degrees Fahrenheit or 23 to 29 degrees Celsius. Pipettes must be calibrated to 60 plus or minus 2 drops, and rotations must be at 180 rotations per minute for 4 minutes. It is read as reactive, weakly reactive, or non-reactive. Next, we'll talk about the RPR. This uses macroscopic flocculation. It's a modified VDRL test. The antigen is attached to charcoal, which aids in visualization. Flocculation appears as black clumps against a white background. Serum does not have to be heated, and a microscope is not necessary. There are strict guidelines for quality control, including that the needles must be calibrated to 60 drops per milliliter. Needles must be 20 gauge, and cards that are used are 18 millimeters in diameter. The rotator must rotate at 100 plus or minus 2 for 8 minutes, and the temperature range is 73 to 85 or 23 to 29. Reduced temperatures can lead to false negatives. Antigen suspensions are only good for 3 months or the expiration date. New lots are tested in parallel for 2 days before placing the kit into use. Next, we'll talk about the treponemal tests or confirmatory tests. These confirm the presence of specific anti-treponema palladium in patient serum. Occasionally, there can be a false positive result, most often in women with lupus. The fluorescent treponemal antibody absorption test. This test uses an indirect fluorescent antibody that uses treponemal palladium Nichols strain, NICHOLS. Heat inactivated serum is mixed with sorbent. Sorbent is a solution made from a culture of Reiter, R-E-I-T-E-R, treponemes that removes antibodies to group antigens common to Treponema palladium and non-pathogenic treponemes. This makes the test more specific. Active systemic lupus can cause false positive reactions, which appear as a beaded fluorescence on the slide. Absorbed patient serum is added to the antigen smears and anti-IgG labeled with FITC is added. Positive tests show green fluorescent treponemes under a fluorescent microscope. The test is reported as non-reactive or reactive. This shows how a test is set up and run. Next, we have microhemagglutination assays. These are based on agglutination by specific antibodies in patient serum with different types of erythrocytes sensitized to Treponema palladium antigens. They utilize passive hemagglutination. Agglutination of the sensitized cells is a positive test, while negative tests fail to agglutinate and form a button of erythrocytes in the well or the test tube. ELISA uses the nickel strain of Treponema palladium antigen fixed to metal beads. The antibody source is patient serum, and the detection system is horseradish peroxidase conjugated with anti-human IgG. Results are read on a spectrophotometer for color development. There are a few other strains of Treponema you should know. Treponema palladium subspecies pertenu causes yaws, Y-A-W-S. Subspecies endemicum causes non-venereal epidemic syphilis, or Bejel, B-E-J-E-L. Treponema caritium causes Pinta, P-I-N-T-A. And denticola is non-pathogenic. It's found in the oral cavity. Moving on to Lyme disease. It was named in 1977 when arthritis was observed in a cluster of children around Lyme, Connecticut. It is caused by the spirochete Borrelia burgdorferi. It is transmitted by an arthropod, the deer tick, Iodes scapularis. Iodes ticks are much smaller than common dog ticks. In the larval and nymphal stage, they are no bigger than a pinhead. In the United States, they are mostly localized to the northeastern, mid-Atlantic, and upper north-central regions, and to several counties in northwestern California. This disease is characterized by the development of a red papule at the site of the bite. It is called erythema chronicum migrans, or a bullseye rash. It usually starts out at about 5 centimeters in the early stages, but can expand to form centric rings with a clear center. Lesions may last for several months, and late-stage Lyme disease is most commonly associated with arthritis. Larger joints like the knees, shoulders, and elbows are affected. In 15% of cases, neurologic abnormalities may be seen, such as aseptic meningitis, facial nerve palsy, encephalitis, and cranial neuritis. Next, we'll cover the diagnosis of Lyme disease. The physical exam is paramount. The clinician should determine history of prior tick bite or visitation of a tick-infested area. Isolation of the organism involves skin biopsy, lymph node aspiration, synovial fluid, CSF, or blood would yield low rate of recovery and have a turnaround time of 12 weeks. This makes it extremely impractical. Serologic tests are done through indirect immunofluorescent assay, or ELISA. The Western blot is used to confirm IFA and ELISA results. Demonstration of a fourfold increase in titer on paired sera taken at 6 to 8 week intervals confirms the diagnosis. False negatives may occur during the first few weeks of infection because there are insufficient quantities of antibody to show a positive result. False positives may occur with other spirochete infections such as syphilis, relapsing fever, and autoimmune disorders. The treatment generally includes antibiotics. For oral treatment, this includes doxycycline and amoxicillin. Patients with certain neurological or cardiac forms of illness may require IV treatment with drugs such as ceftriaxone or penicillin. Prevention includes avoiding tick habitats, particularly in spring and summer when nymphal ticks feed. Ticks favor a moist, shaded environment, especially areas with leaf litter and low-lying vegetation in wooded, bushy, or overgrown grassy habitats. You should use personal protection, wear light-colored clothing so that ticks can be spotted more easily, wear long sleeves and tuck your pants into your socks, and wear de-insect repellent. You should perform a tick check. Transmission of the bacteria causing Lyme disease is unlikely to occur during the first 36 hours the tick is attached. You should remove them using fine-tipped tweezers to pull the tick body away from the skin. The bacteria causing the disease is in the midgut or salivary glands, so the tick mouth parts being stuck in the skin is not cause for alarm. And of course, you should cleanse the skin thoroughly. Southern tick-associated rash illnesses. These are similar to Lyme disease, but are seen in southeastern and south-central states, and they are associated with the bite of the Lone Star tick. So that's it for this lecture. Don't forget to take your quiz on Canvas.